have a session on medical advances. We're going to have Laura Baker speak, mesothelioma warrior. We'll have several people join us online. Dr. Markowitz, we have Dr. Moline here. We have Dr. Black coming to us from Montana. Dr. Wolf is here, and Chris Oliver wasn't able to join us, but I will just comment that she, like Dick Lemon earlier, was concerned about the NIOSH roadmap and felt that their emphasis on elongated mineral particles was a bit premature. We don't have science to back this at the moment. The other point I want to make is that we have heard from the two senators from Montana, Senator Tester, who has been a great supporter of ADAO, and likewise Senator Janes. And both of their letters comment about Dr. Black, who will be speaking with us. While they've been supportive of Dr. Black and the card clinic, the comment I want to make is that Dr. Black personally and the activities of the card clinic have come under legal scrutiny by some industrial powers that be that have been unhappy about the success and honest assessment of patients that the card clinic has been able to undertake over the years, and have proceeded with litigation, which some of us have stepped up to try to assist with, protecting Dr. Black. But I think that Dr. Daines, for example, is well aware of the problem of asbestos, as he writes in his letter, that it affects thousands of Americans, not just those in Montana, and that he wants to see that those in Montana have the resources to help. And I think part of the resources to help them and all other Americans would be to ban asbestos, and we hope that that's something that will happen. So let us start this session with the presentation of Laura Baker. What I want to encourage you to do, we have some really cutting-edge science and cutting-edge scientists here today. I'm not going to speak about each of them individually, but please read their bios, which are in the program. You are hearing from the best of the best that have been doing asbestos-related research. So let us hear first, however, from a warrior, Laura Baker.
Good morning, everyone. I'm Laura Baker from St. Louis, Missouri. I'd like to thank every expert, guest speaker, and families for being here today and for the unity we have shared. I have been a supporting family member of the Asbestos Disease Awareness Organization for 12 years in honor of my family members in the Libby, Montana health emergency that was declared in 2009. I have over 20 immediate and extended family members and many friends in Libby's health emergency. In November of 1999, the EPA sent a team of investigators to the small town of Libby, Montana, in response to media reports of a high incidence of asbestos-related disease among its residents. The response team found that homes, yards, school playgrounds, and industrial sites in Libby were contaminated with asbestos as a result of the W.R. Grayson Company's nearby vermiculite mining and processing operations. The community-wide exposure in Libby is one of the largest environmental and public health disasters our nation has faced. These impacts have made Libby one of EPA's most notorious sites and a high priority Superfund cleanup. 23 years later, EPA is still working on the cleanup in Libby, Montana. It's been a long process. To date in Libby, I have 2 family members that have been diagnosed, one with asbestosis and one with mesothelioma. I also have a cousin from Virginia that died from mesothelioma. Asbestos exposure risk has been a national health risk for decades. 12 years ago, I began speaking up and advocating on the environmental exposures of my family members in Libby's asbestos EPA Superfund and Navajo Nation Uranium EPA Superfund. In 2014, I learned that I have been facing the environmental exposure risks of nuclear radioactive waste in the St. Louis region's EPA Superfund, making it the third EPA Superfund of my family. All three of these EPA Superfund sites are listed in EPA's priority top 10. These are the reasons behind my 12 years of personal efforts, including many meetings that I have attended with EPA Chemical Safety Division, and including the White House Environmental Justice Advisory Council. Today is a blessing for me to be able to be here with all of you again. As of December 2019, I was diagnosed with stage 3 lung cancer. My symptoms began with 2 bouts of severe pneumonia in the prior years. In January of 2020, I began 16 months of cancer treatments consisting of a lung biopsy, radiation, chemotherapy, and immunotherapy. 2 years later, in January of 2022, I was re-diagnosed with stage 4 lung cancer. On February 1st, a biopsy was taken and sent to the National Cancer Institute's research. The biopsy showed my cancer has a very rare genetic mutation. Also on February 1st, I officially became one of 1,000 cancer patients nationwide in the National Cancer Institute's Cancer Moonshot Research Program, which was reignited by President Biden the very next day. I thank my cancer care team under Dr. Brian Fowler for their continued care, and I thank President Biden for reigniting the National Cancer Institute Cancer Moonshot Program and for making it a priority to find cures for cancer. Since the opening of the Libby, Montana Card Clinic in 2005, Dr. Brad Black has medically served and diagnosed hundreds of patients as the medical director. Dr. Black is Senior Medical and Research Advisor for the Libby Card Clinic. He continues to be a leading advocate for the healthcare, treatment, and research to benefit those impacted by Libby's amphibole asbestos. Dr. Black has become an expert in identifying and managing Libby amphibole asbestos diseases and was an integral part in the planning and implementation of the original Agency for Toxic Substances and Disease Registry Asbestos Health Screening Program. His dedication to all the families in Libby and those across the United States affected by Libby's amphibole asbestos is greatly appreciated by me and the many patients he has served in the medical field. Over the past 16 years, Dr. Black has presented updates to all of us at the Asbestos Disease Awareness Organization conferences. And today you will learn about diagnosing and treating mesothelioma and other asbestos-related diseases. I am proud to introduce to you today our panel speakers, Ms. Christine Oliver, Stephen Markowitz, Dr. Brad Black, Jacqueline Moline, and Andrea Wolf, with a question and answer session to follow. So I thank you, Linda, and fellow ADAO members and supporters. I hope to see you again in 2023. Thank you for the unity and support to hold our legislators in the House and Senate accountable to addressing the legacy asbestos issues and protecting public health with the Alan Reinstein Ban Asbestos now act. Thank you.
Thank you so much, Laura. Our next speaker is going to be Dr. Stephen Markowitz. So without further ado, Dr. Markowitz.
Greetings, everybody, and I want to thank Linda and ADAO for inviting me back to speak about lung cancer. And I also want to thank the previous speaker, Laura, for sharing her story with us, and we wish you the best. Glad you're getting excellent care. And what I'm going to talk about is a way in which I think we can try to avoid future suffering. Okay, so yeah, I'm funded by the Department of Energy to conduct lung cancer screening, and I have been for the past 20 years. So there's a puzzle around lung cancer screening, and I want to share what the puzzle is, and I want to help understanding why we have this puzzle. So lung cancer is the most common cause of death, cancer death in the United States, no question. It is also, among the established types of cancer screening, the least popular or common occasion for screening. This year, there will be 130 deaths from lung cancer in the United States. And it's both among men and women. Lung cancer death is the most common cause of cancer death. 22% of men, 22% of women. It equals the next two most common causes of death in each gender. So for women, it's equivalent to breast cancer plus colon cancer deaths, and in men, prostate and colon cancer deaths. So a lot of death due to lung cancer. And yet, lung cancer has the least rate of screening. Breast cancer and colon cancer, we have very good screening rates, 70 to 80% at present over the last couple of years. Prostate cancer, actually, there's no longer really any recommended screening for prostate cancer. The U.S. Preventive Services Task Force reviewed this a number of years ago and very much restricted its recommendations for prostate cancer screening. Yet, lung cancer, which was approved by them 2013, so it's been 9 years now, lung cancer screening is by far and away the least most common type of screening at present. And we need to change this. Among people exposed to asbestos, asbestos causes far more deaths from lung cancer than from mesothelioma. Obviously, all deaths caused by asbestos are tragic and terrible, but if you look at the numbers, lung cancer far outweighs the number of mesothelioma deaths per year due to asbestos. So, we've been talking, ADAO has really been in the forefront, suing EPA to address legacy asbestos, and there's been tremendous progress on that. By the way, I'm at the local library doing this talk outside, so there may be a little bit of background noise, I apologize. But in any event, so a lot of focus on legacy asbestos. We also need to focus on what Arthur referred to before at the beginning as the legacy of asbestos. I'm talking about exposure, particularly heavy exposure that occurred in the 60s, 70s, into the 80s, and to a lesser extent, but persistent into the 90s, to the present. But if you think about the people heavily exposed in the 70s into the 80s, they're now of the age 60, 70, and 80, where they are at the highest risk for lung cancer. And I found this table, I think some will appreciate this. This is from a classic study by Bill Nicholson at Mount Sinai, 1982. This is Bill Nicholson and Dr. Selikoff predicting actually what's going to happen over the next several decades with asbestos-related disease. And they focused in on these traditional occupations, industries at high risk, again, going back in time. And of course, the actual population at risk from asbestos is far broader than this. So in terms of the legacy of asbestos, what do we actually have to offer? What we have is an annual low-dose chest CT scan, which can detect lung cancer at an early stage. I mean, stage 1 or stage 2, and a person can avoid being diagnosed at stage 3 or stage 4. Here's the slide with a picture of a CT scan. This is from the middle of a chest, and it's just a slice from a CT scan, a low-dose scan, and it shows actually on the left, there's a mass in the left lung. Excuse me, it's the right lung, but It's on your left side, and it's surrounded by the black, which is the lung tissue, and you can see that isolated opacity or white area in the lung, and that's an early stage lung cancer picked up by low dose CT. That could be removed by Dr. Flores, Dr. Wolf, probably with a scope, and the person can actually then lead a normal life, be cured of lung cancer. It's a 30-second scan. It's simpler than colonoscopy, far simpler than colonoscopy. It's less uncomfortable than mammography. There are no injections, there's low dose radiation, and the person just has to remember to do it. It's now actually available at 4,300 different radiology facilities across the country, so it's widely available. Good news, also, more people are eligible for lung cancer screening than ever. The U.S. Preventive Services Task Force expanded their guidelines last year. I'll show you the next slide where I provide that detail. As I just mentioned, many radiology facilities offer this expert service, and low-dose CT is increasingly reimbursed by both private insurance and by government insurance. So last year, the arbiters of who should get screened expanded eligibility for low-dose CT, and they added what was amount to several million people who are now eligible for CT reimbursed by insurance. So these are the current guidelines: age 50 to age 80, so it's broader. Smoked at least 20 pack years. It was 30 pack years previously, so lighter smokers are now eligible if they quit 15 years or less ago. So those are the current reimbursable guidelines for lung cancer screening. You'll notice that, of course, the guidelines still don't address asbestos or any of the other occupational environmental carcinogens, silica, radon, diesel exhaust, and the like. This is a major gap, a gap that really ultimately, unfortunately, is sort of on us to promote lung cancer screening among the populations that we care about. However, the major problem, piece of bad news is that almost nobody is taking advantage of lung cancer screening. Only 1 in 15 people who are eligible, according to those smoking and age guidelines I mentioned before, are even going for lung cancer screening. Why not? That's the enigma. They're not going, I think, because they're afraid of the lung cancer diagnosis. Some people aren't aware of this. Their primary care doctors aren't promoting it among them. Some people, it's a question of payment. That it would be out of pocket for them if they don't meet the guidelines. So there are a number of current obstacles, but we need to do something about this, the fact that we are not taking advantage of this hugely readily available opportunity to save lives. So our job really at this point is to educate and to motivate people. So what we need to do, the people who are on this call and this conference now, is to think of your family and friends who would be eligible for lung cancer screening age 50 and over, if they have a smoking history, even if they quit a long time ago, if they had a history of exposure to asbestos or worked in a job where they were exposed either to asbestos or any of the other lung carcinogens, if you have a family history of lung cancer, frankly, if you have a personal history of any type of cancer, and finally, if you have a history of chronic lung disease, those are the people who should be going for lung cancer screening. So think about your family and friends and tell them about annual low-dose CT. It's easy to do, it's readily available, and they should do it. And then beyond that, with the organizations, with the ways in which we contact the broader public, we need to get out there, educate, and motivate people to get screened. Thank you very much.
Thank you very much, Steve. One should add, I should add that Steve Markowitz, more than probably anybody else in this country, has been an advocate for this, for promoting low-dose CT lung cancer screening, has written articles that are published, and needs to be commended for this work. So thank you. Our next speaker is Dr. Moline. Dr. Jacqueline Moline has also been laboring in the vineyards of asbestos-related work with some particularly special areas of interest, and we look forward to your presentation. Thank you.
Hi, good morning, everyone, and it's a real pleasure to be here. I'm going to talk about asbestos-related diseases and the importance of history. Asbestos-related cancers include laryngeal cancer, mesothelioma, ovarian cancer, and lung cancer after asbestos is breathed into the respiratory system. Mesothelioma trends, as we've been talking about with legacy asbestos, we see that there was a peak in around 1990 for mesothelioma among men, but in women it's actually been fairly steady to slightly increasing, and we can talk about some of those reasons in a moment. If we look at mesothelioma mortality rates, we see that they are highest in the Northeast, Northwest, and Midwest, and Louisiana is also in there because of shipyards. So we see in the areas where there is either mining or there are shipyards that much of the mesothelioma mortality is the highest in these areas. This isn't to say that mesothelioma doesn't occur throughout the United States. In women, mesothelioma is highest in areas where there were shipyards, and that's from take-home exposure, meaning that they lived with somebody who worked in asbestos shipyards, brought home the asbestos fibers, they shook out their clothes, they contaminated the household, the workers contaminated the households, and it led to the development of mesothelioma in women. When we look most recently in women, the three highest occupations for the number of mesothelioma deaths in 2020, and this is from a report from the CDC in the mortality and morbidity weekly report that comes out, was homemakers, school teachers, and registered nurses. This is just what their occupations were. It doesn't talk about what their exposures were. So homemakers could have had it from living with someone who worked with asbestos. Same with teachers, same with nurses. Nurses could have had occupational exposure, and we'll get into how they could have had that occupational exposure. And teachers may have had it from their own use, not necessarily from the school, but their own personal use, which we'll talk about. So that's where we transition into talc, and by talc I mean talc contaminated with asbestos. So talc is used both in the industrial setting, it's used in rubber, plastic, ceramic, paint, and many other products, and it's also used in cosmetic products, such as talcum powder, face and body powders. Talc with asbestos is considered a possible carcinogen. Well, actually, it's considered a definite carcinogen, it's group 1. And then non-asbestiform talc is considered 2B. The use of cosmetic talc is reported as high as 50% in some countries. Now, an industrial talc mine in New York State, if we look, and there's a particular company, there's data from the talc mine workers for about 40 years. They found elevated rates of lung cancer. They found 2 deaths from mesothelioma. That was early on. And the authors concluded it was unlikely that mesothelioma cases were due to the talc ore dust because there was a short latency and there was a brief employment at the mine. But there were some issues with that data, and there were some issues with the numbers. Because when they looked, and they actually found, by 1986, there were actually 8 confirmed cases of mesothelioma, and the occupational exposure to dust from these talc mines led to excess mesothelioma cases. So the rate was actually 5 to 10 times what the background rate was from during that time frame. There were 5 new male cases, 3 new female cases, and there was an increase in talc exposure duration that was associated with more lung fiber burden for both fibrous and non-fibrous talc. There were asbestos bodies seen in individuals with more than 10 years exposure. There still were new cases that were identified as the years went on. There were 5 more cases. The incidence rate now was statistically significant, and it was 5 times what the general population was. Tremolite and anthophyllite, the fibers of asbestos that are found coexisting with talc as it is mined, were seen in both the mine and mill dust, and they were also seen in the lungs of the talc workers. So the increased risk of mesothelioma was finally attributed to the inhalation of these fibers from the talc mining. In the United States, for non-industrial, but for cosmetic talc use, we look at the various different brands of talc that were used, and we can see the usage from various products in the United States were pretty prevalent. In some parts of the country, up to 80% of people use cosmetic talc, particularly in the more humid South. There's also differences between blacks and whites in terms of use of talcum powder. Now, women were discussed as having what's called idiopathic mesothelioma. And for occupation, less than 50% of women were found to have an occupation that associated them with malignant mesothelioma. They have had these home exposures from family members, and in studies there were limited categories of work. They weren't asking the right questions. They were limiting the questions, they were limiting the categories in which the researchers could categorize someone as actually having an exposure. As a result, they were categorized as having no exposure when in fact they had exposure, they just weren't asking them the right questions. Other studies have shown that tremolite asbestos fibers were found in the lungs of women with malignant mesothelioma. They didn't have any asbestos contact that they knew of. What they did have was cosmetic talc use. The authors even stated, and this was decades ago, that cosmetic talc could be the reason for these findings, and these are the same types of asbestos fibers that are commonly seen in cosmetic talc. There were non-occupational exposures, but none of these papers, they're all silent on whether talc was used by any of the people. Now, how would a nurse occupationally be exposed to asbestos? Well, they powder patients. They use a lot of cosmetic talc when they are keeping patients comfortable, especially patients who may have incontinence. There's a lot of talcum powder that is being used. Years ago, talcum powder was used in gloves. No one remembers that. Now we have talc-free gloves, but they were used. People put talc into gloves in hairdressing as well, so as a way of getting it in, and it was used in a variety of different occupations. There have been a couple case series. I've had the opportunity to write one of them, and the goal of writing these case series for me was to alert physicians that talc was a potential exposure, asbestos exposure. I am really pleased to say that I will be seeing a patient this week who had a procedure where talc was used in their body and is concerned that it may cause a problem for him many years later. He's aware of it because he read the scientific literature and said, could this be an issue for me? So he's coming in, hopefully his low-dose CT will be negative, but it's preventive, and it's because he had the information he needed. So these two case series, one was written by, I wrote with some colleagues, as well as Dr. Emery and Dr. Maddox. We had about 108 patients where we were unaware of any other asbestos exposure apart from talc who developed mesothelioma. There were similar trends in both the papers, predominantly female. There were more peritoneal cases than would be expected. Typically, peritoneal cases occur in about 10% of all mesotheliomas. Here we saw about 30% were seen in both of my paper and in Dr. Emery's paper. We found asbestos in lymph nodes of some of the patients, or some of the individuals in the paper, and it was the same types of asbestos that are found in cosmetic talc. Of interest, 7 of 108 were cosmetologists, hairdressers, or occurred in barbershops. Again, talcum powder is used in the occupation to clean off the neck. It's used by some folks when they're for the gloves and in other things. People are unaware that they were diapered, but the diaperers and the diaperees have exposure to asbestos, there's perineal cosmetic talc use during the diapering. And individuals who use cosmetic talc diapering children, were diapered as children, did it as an occupation, recall talcum powder being applied after bathing. Many years later, may develop mesothelioma. I've had individuals who were nurses who worked on the pediatric units where they used cosmetic talc, so they were occupationally exposed doing a task that they might also have been doing at home on their own children. And that visual, it's of the talcum powder, the cloud, using special lighting to see all the asbestos and the powder in the air. It's very easily aerosolized. I have a couple representative cases that I'd just like to go through, just to give you a sense of how this can be so insidious and how critical it is to come up with a good history. So a 62-year-old male computer programmer grew up in rural Pennsylvania, had worsening shortness of breath and a dry cough. He didn't have COVID. His shortness of breath worsened. He went, had an x-ray, and it showed white out of the lung, meaning he had a pleural effusion. He didn't, eventually the pathology showed malignant mesothelioma. He was treated with pleurectomy and immunotherapy. So he grew up in central PA. His family owned a farm that had vegetables and cattle. He didn't work on the farm equipment, so didn't have brake exposure. After attending college on a swimming scholarship, he began working in an office. His wife was a psychologist. They had no home renovations and didn't work on cars. His medical history was unremarkable, and there was no family history. He did have exposure to baby powder. His mom used it when she was changing his diapers and after a bath, and he was a swimmer. Swimmers use bathing powder on their swim caps. It's a way of both keeping the integrity of the swim caps and also getting it on their head. Much easier, and he used it all the time on his swim cap, and he also used it on his body, and he continued this practice for decades. Another case is a teacher who notes her clothes are beginning to fit her very tightly, even though she's dieting and losing several pounds. She goes to her doctor, who recommends a laxative. The abdominal distension got worse. She's found that she has ascites, which is fluid in the lungs. She finally gets testing done, and some atypical cells were seen. There's concern she might have ovarian cancer. She has a laparoscopy, a procedure to look into her abdomen, and it shows diffuse carcinomatosis, which is the finding we see with mesothelioma, as well as you can see that with metastatic ovarian cancer. The pathology showed malignant mesothelioma. She was referred to a specialty center where she underwent cytoreductive surgery with peritoneal chemotherapy. She does well for 3 years, then has a recurrence. So where's her exposure? She was a special ed teacher in a school built in 1992 after asbestos was no longer used in schools. Her husband was an office-based draftsman. Her father was a physics teacher. Her mother was a librarian. Her mom was a person who sold cosmetics on the side. From the age of 6, she used various talcum powders her mom would obtain. She used it until 2018 when she was diagnosed, and she also used but she used cornstarch on her kids when she changed their diapers. So really, just for future considerations, what I'd like everyone to think about is there's attention to true background rates for fiber burdens. We need to know what, when people are being pushed to do fiber burdens, what is the true background rate? We need to really obtain a history of all potential exposures. The swimming caps, for example, if you're not asking somebody what they did, what their habits were, what their hobbies were, you may not get to all their sources of asbestos exposure and recognize that talc use can be an asbestos exposure. So I thank you for the time, and I look forward to hearing from the other speakers today. Thank you.
Thank you, Dr. Moline. One of the papers that I read many years ago, apropos your patient who's coming in this week, was a young Navy sailor who had heart surgery in the 1940s. And they put talcum powder in the chest, which was commonly done in those days. 30 years later, got a meso. So that's even been, these case reports are in the literature. Our next speaker is going to be Dr. Brad Black, coming to us from Montana. For those of you that don't know Dr. Black, he has been the medical director for many, many years at the CARD Clinic, the Center for Asbestos-Related Disease in Libby. And good morning, Brad. Good to have you with us.
Well, thank you, Arthur. I really appreciate the opportunity to communicate with everybody at this conference. Even if it is from Zoom, I would love to be there. It did not work out this time, but I do miss being there and having that personal contact. But anyway, I will move ahead with this. Today, I just would like to speak with you. First of all, I've been a physician in Libby for since 1977, and then involved in the issues related to asbestos exposure and health outcomes since 2000, and so the last 22 years have been overseeing screening and monitoring of 4,500 people with asbestos disease. We screened over 10,000 since we've been in open. So anyway, I'd like to move ahead. I'm staying on slide 1 in my introduction. I would like to, before I start on the other slides, just to key in on the points of emphasis today. Libby could be talked on for hours, and so today I'm focused on some real issues that relate to understanding detection and recognition of asbestos disease related to the living amphibole exposure. We got to remember, living amphibole is not not asbestos, truly not asbestos. It's non-regulated. However, its hazards remain high in spite of that. And so because of the fact it's non-regulated does not imply that it's not just as dangerous. So, and the other thing to remember is that living amphibole that contaminates the living vermiculite contributes to a significant amount of the legacy asbestos that will continue to create an exposure risk through the long term. The other key issue that I would want to address today, because it pertains to diagnosing the lung disease from the living amphibole exposure, there's a very pattern of pleural pulmonary fibrosis, and it's not well recognized, certainly not around the country, yet exposure is occurring all over the country. So these are the issues that really we need to talk about today. So I wanted to move on to then on slide 2. And I believe this slide shows you a picture of the old mine, the Vermiculite Mountain, where you can see about 200 feet of this mountain have been removed over the time frame of 1923 to 1990, when the Vermiculite mine closed. About 200 feet of the mountain is gone. Now that translates to about 3.5 million tons of ore that were milled and transported throughout the United States. And on slide 3, that transportation went to over 250 processing facilities across the United States. When the larger red circles represent the higher tonnage that went to those areas. You'll look in Ohio. One of the largest circles was in Marysville, Ohio, where the Scott's Company was the biggest importer of the living vermiculite in the early years. So anyway, slide 4 does demonstrate the unprocessed vermiculite. You'll see it as a mica-like mineral. It's micaceous, that is, it's a sheet silicate. The crystal is composed of multiple thin plates. And between those plates is the presence of water molecules. And so the processing required a exfoliation process where the unprocessed vermiculite was heated to over 800 degrees centigrade. The steam forces between the individual plates would then separate due to those forces from steam. and expand these particles to 10 times or greater in size from their original form. So slide 5 shows the exfoliated product. I bring it up every time because I have a lot of people that still don't know what it looks like. So I always bring it up to show them what the product looks like. So slide 5 will show a pretty typical example of the particles that then become used for insulation and other applications. It's interesting, this mineral goes from a hard micaceous particle to a spongy type particle that made it much more suitable, of course, for its applications. So slide 6, once again, I think we all know zonolite attic insulation was handy to put in to add on to insulation in homes, and was poured into homes. Very convenient to install probably in over 30 million homes. It's estimated at least 30 million homes. Can you imagine the impact on the installers? Certainly, we have all the reason to know that many of them probably became ill, and probably a lot of them didn't know why. But in the past, actually, I had a long distance communication from a gentleman in Connecticut who called me when we were in the early 2000s, and he had been to his pulmonologist in his area. And he ended up having asbestos disease, but didn't know really where it came until they explored it. And he realized at an early age, when he was in his probably just out of high school, he insulated homes, probably a total of less than 20 homes, where he would spend maybe 4 hours on each home, maybe a total of 60, 70 hours of exposure within the installation of this insulation. Turned out to be the green bags of zonolite, and that was the origin of his exposure. He sent me his CT study of his chest, and it was just unbelievable what this 60 hours of exposure did to create within his chest. And so it's an example of where this stuff is everywhere. And if we're not looking for it and not thinking about it, it's easy to miss it. His happened to be very more characteristic in the appearance, so that it was more easily recognized. That's not true of so many. So then slide 7, after we looked at the insulation, we looked at it on the slide, but now looking at it with electron microscopy, this insulation, you can see, had bundles of living amphibole fibers on this particular slide. Going to slide 8, this is not news of any kind. Living vermiculite, though it was only less than 1% by weight in the product, the zonolite product, with activity-based sampling, which was done by Deborah Grace in 1978 on an internal study, which that later got revealed in the 1990s in court, showed that their workers that were involved in pouring bags of their zonolite product into containers experienced exposures up to almost 8 fibers per cc. So this was very well known in 1978 and verified by activity-based sampling that this product generates tremendous exposure risk. Even to the point where not just in Libby were there problems, in-product users around the country have developed problems. There's an article published in a few early 2000s, probably 2004, a gentleman that was using vermiculite for packing materials while working in the Air Force. He did about 3 or 4 hours a day over a 10-year period, and he ended up with advanced lung disease. So the awareness was occurring in certain parts of the country, but it just tells you that's probably the tip of the iceberg. So slide 9, I won't repeat all that. It just talks about our experience and the numbers of people that we are involved with. We do have extensive monitoring over 22 years. Many of these people have follow-ups every 1 to 3 year intervals. So we've kept a close tab on the majority of our patient population. So the things that we've learned, obviously, over this time frame is a low-level exposure and disease. This is something that not only had we observed in the clinical setting, but also this was also observed in studies in the Marysville, Ohio cohort, which was the largest import of that utilized the Libby vermiculite. Studies from the University of Cincinnati showed very low exposures. Let's go to that next slide. Their health studies at the University of Cincinnati involved the Marysville cohort, which was were employees of the Scott's Company, and they published results of their health studies, and they recognized that with cumulative fiber exposures of 2.21 fiber years, they noted that there was development of pleural fibrosis in this workforce. There was a unique situation here in that the company had very impressive exposure histories. They sampled regularly. They had good estimations of exposure. And so they were able to be much more accurate in terms of recognizing dose and response. And when you look at that, and then you think about the OSHA permissible level, 0.1 fiber per cc, that would generate 4.5 fiber years for a worker of 45 years. So here we are with this Libby amphibole that appears to generate pleural fibrosis at a much lower cumulative fiber exposure. In subsequent follow-up of this Marysville cohort has demonstrated that it is, and that this is from Jim Lockheed's group there. Dr. Lockheed estimated that the Libby amphibole generates a disease at 3 to 10 times less what we have experienced with other asbestos exposures. So slide 12, we're dealing with the key difference here in the Libby amphibole is that it's a progressive pleural fibrosis. In other words, maybe I can describe it best as I left medical school, and when was that? Probably 1974. We were taught that pleural plaques were a marker of exposure, a biomarker of exposure, not disease. But the asbestosis, that is scarring within the parenchymal tissue, the lung tissue itself, is really the disease. And so that was what we were left with, and that was our understanding of those particular pleural changes. But in Libby, this has been what's fooled everybody, and including us, for years. This pleural fibrosis was starting out as a very thin layer and then progressing over time to become thicker, and then became apparent over time. But people did not get traditional plaques. A lot of them didn't. And they would have this thin layer develop in the pleural tissue that was hard to see on X-ray and a challenge to see on scan in the early stages. So anyway, so in 2000, I'm sorry, slide 13, we published an article. This really was entitled "Not Your Grandfather's Asbestosis." That relates to a quote from Dr. Steve Levan, who came to Libby and looked at multiple cases and was just totally taken back with the different pattern of fibrosis. And that was the comment he made. He was struck by the pattern, the rapid progression, and the severe chest pain that these patients experienced. And the plaques were less frequent, but still associated with progressive disease, as pointed out by Dr. Whitehouse in his publication in the past. So anyway, slide 15. How was Libby amphibole pleural pulmonary disease, I'm sorry, pleural pulmonary fibrosis overlooked for so many years? Clearly, a lack of understanding of exposure risk was a key issue. that pertained to a little bit of, once again, corporate connivery, knowing, looking back and knowing full well how much they knew and how much they hid. And so the medical community did not have any knowledge of ongoing exposure, and had been reassured that we had a safe material that was now being processed. So then the very pattern of fibrosis, the appearance on CT of the chest, is very, the pattern is very challenging, and it's not easy to recognize. And the findings can be very nonspecific, and that the pleural fibrosis is certainly through the early to moderate stages of the disease doesn't calcify, so it doesn't stand out as a asbestos-related problem, and so it's easily overlooked. And I want to show you a picture of that in a little bit. Slide 19, this is a disturbing case I wanted to present to you because it is an insulation exposure case. A 52-year-old mother who moved to the Libby area, about 13 miles from Libby, lived in a house for 10 years, an older home owned by the state, and they had an office building next to it. They went through 10 years, and then in 2000 realized they were in a home with this insulation in the attic of this older structure. She developed pleuritis in about 2016. Now has had progressive bilateral pleuritis. Her chest X-ray shows a normal. It's on the left, on your left, and the slide should be the normal film. And on the right, you'll see bands of scarring and pleural scarring on both sides of the chest. Her prognosis is extremely poor. She did have thoracoscopy, had documented fibrosis of the chest, and the surgeon thought it was most likely asbestos caused. Number 20 slide would be the 75-year-old former Zonalite worker. And I show you this slide mainly because it's the challenges of detection and diagnosis. He had severe problems with chest shortness of breath. Was diagnosed in 1989 by Dr. Whitehouse, the pulmonologist in Spokane, that first recognized what was going on with Libby. There's been no radiologic recognition until 2014, and one of our thoracic radiologists, Dr. Henschke, recognized it. He did have thoracoscopy for lobectomy, and you'll see on slide 21, there is a very thin layering. I can't, if you look toward the right part of that picture of the tissue, there's a very thin layering, a whitish layer of fibrosis over the chest, which is what we were looking at in the CT study before. But I kind of had to run through this. But the point here is this is subtle stuff, but yet very impactful health-wise. And if you don't know what you're looking for, it's easy to miss it. And I think of all the things that we need to do here is, and the last slide is, we need to be out there educating and making people aware of what this looks like and how to detect it. It's extremely important, especially in view of all the legacy asbestos and the fact that it's still not regulated. So I will wrap it up there. Thank you very much.
Brad, your work and laboring in that vineyard of Libby has been remarkable, and the community would not know much about what it knows if it hadn't been for your work and that of Dr. Whitehouse. And it's been a privilege for me to be out there and visit with you and agree with my colleague Steve Levin that this is not your grandfather's asbestosis. So thank you for that. Our last speaker this morning is Dr. Andrea Wolf. She's a chest surgeon at Mount Sinai, the place that I trained at and learned about my asbestos materials and background, training with Dr. Selikoff. And it's wonderful to have colleagues that are continuing that at Mount Sinai. And we'll have Dr. Wolf present on some of her experiences with caring for patients and operating on patients that have had asbestos-related cancers and other diseases.
So as with any talk, I always start by saying I have no financial disclosures because I don't. But I confess a major disclosure, particularly for this audience, and it's actually one I'm very proud of. I work at Mount Sinai. I've worked there for 10 years. It's the home of the Selikoff Center. It is the center where Dr. Selikoff discovered the relationship and publicized the relationship between asbestos and the cancers it causes. Linda asked me to speak about something that is very near and dear to me, and that's taking care of patients with mesothelioma and asbestos-related diseases. So I'm approaching this talk with a roadmap or a plan for screening, diagnosis, and treatment. Now, screening is done to look for disease in an asymptomatic population. So the classic example of this, that is a population of patients without any symptoms. So the classic example is the mammogram. It's done to look for breast cancer in women without any lump or detectable mass. That's different from a diagnostic test. A diagnostic test is done to look for disease in someone who has symptoms. So here, this is a chest CT in a man, a 78-year-old man who had worked in the shipyards when he was young. And he had presented with shortness of breath and was found to have a pleural effusion or fluid in between the lung and the rib cage. And he underwent a number of tests because initially it was not clear what was causing this. But that little kind of circular thing on the left side of your field, which is on the right side of the lung, represents that pleural effusion. He was later found to have malignant pleural mesothelioma. Linda and the folks at the ADAO can tell you they routinely field calls, texts, emails, and other contact from people affected by asbestos. That includes patients and caregivers of patients with asbestos-related lung diseases like mesothelioma. But not only these people, also people who've been exposed to asbestos, like Dr. Moline's patient who had asbestos-contaminated talc placed in his chest. So there are currently no good screening tests for mesothelioma or asbestos-related lung disease. As Dr. Black discussed in his Libby amphibial-exposed patients, low-dose chest CT, breathing function tests, these can help and may be appropriate, but there is currently no accepted standard of how to screen people who've been exposed to asbestos. The best right now we can offer is regular medical care. People who've been exposed really need to check in with their doctors. Providers need to have a high index of suspicion for disease, for symptoms such as chest pain, shortness of breath. This is not meant to instill panic or fear in asbestos victims. It's instead meant to inform, arm, and empower you. You need to get ahead of this. Early diagnosis is key. This requires patients to report their symptoms. Don't blow off your symptoms as aging or some other explanation. You need to talk to your doctor. Don't keep your symptoms to yourself. And the doctors, you need to ask the right questions. Dr. Moline gave an outstanding talk earlier on the questions and the importance of a thorough occupational and environmental history. This is all relevant. The doctors need to listen to their patients. There's a 20 to 40-year latency period between exposure to asbestos and the development of asbestos-related diseases like mesothelioma. You need to have a plan for regular medical care, and clinicians need to pay attention and listen to the patients, especially when they have known exposure, and the clinicians need to decipher what that exposure was in order to appropriately follow these patients. So what do you do if you have been diagnosed with an asbestos-related disease? Or, for example, mesothelioma. We encourage you to seek opinions from a center with expertise. For example, I created the New York Mesothelioma program at Mount Sinai with the purpose of providing holistic care to patients with this devastating asbestos-related disease. Here's our team receiving the International Association for the Study on Lung Cancer Cancer Care Team Award at the 2021 World Conference on Lung Cancer. We see patients in our multidisciplinary mesothelioma clinic. We offer social support. We offer a very thorough array of multidisciplinary care that includes not only the people treating the mesothelioma directly, but also palliative care doctors, oncogeneralists, even cardiologists and psychiatrists as needed. We offer social support. We offer enrollment in clinical trials. We're actually near completion of a trial that I'm the principal investigator for that I'm very excited about, evaluating the benefit of a synthetic vaccine called poly-ICLC in patients with mesothelioma who are candidates for surgery. It's an FDA-approved drug that's been used in other cancers, but this is the first trial for patients with mesothelioma. Patients who are candidates for surgery undergo biopsy and injection in the same setting, followed by surgery 2 to 4 weeks later, and therapy as appropriate. We found that this treatment is safe, that it's very well tolerated, and we're currently analyzing the data, but we are seeing signals that in conjunction with other therapies, we're seeing some exciting responses, actual responses. Our hope that this will translate into a delay in progression of disease, a reduction in recurrence of disease, and ultimately a longer and better survival for these patients. So as I mentioned earlier, early diagnosis is key, and that means if you've been exposed, arm yourself, establish a game plan, and ask questions. And the clinicians need to also ask the questions, to gather the history, to have a high index of suspicions. That means to pursue a diagnosis. For example, the cases that Dr. Black showed of the Libby amphibile exposed patients, we have very similar stories where that is your grandfather's asbestos-related disease, and the diagnosis needs to be found early. The earlier diagnosis is made, the better patients will do. This is the CAT scan of the patient who we saw earlier. This was my 78-year-old with asbestos exposure who presented with shortness of breath, and that fluid was sampled and it was found to be non-cancerous. And if you ended there, this man would have died. But luckily, he had a family that advocated for him and a family friend who sent him to me. And we were a little more aggressive pursuing the diagnosis. He was found to have mesothelioma. And because it was early, we were able to do a lung-sparing surgery, the pleurectomy decortication, a procedure where we remove the mesothelioma and the pleural lining, but preserve the lung. And you can remove a lot of tumor that way. This is like a Kentucky Fried Chicken bucket full of tumor while preserving the lung. And this is the same patient 3 years later. So a very, very good outcome. He lived several years. Very good outcome. Early diagnosis is key. Now this is another patient. This man was 47 years old, and for years he actually had felt quite well, but in his history, he had some thought to be lung infection or fluid around the lung related to an infection. He'd even undergone a thoracoscopy, or a procedure where they stick a camera in the chest, as you had seen pictures from Dr. Black's talk, without a diagnosis of cancer. And I ultimately met him and found he had come in with shortness of breath and had a CAT scan that looks like this. And again, the left is on the right and the right is on the left. So the right side of your screen, which represents his left lung, was completely contracted. It was kind of consumed by this process that was mesothelioma. And so he was actually otherwise had not progressed outside of the chest, also eligible for surgery, but his operation was much bigger. And so he required removal not only of that pleural lining, but also the lung itself. And what's left when we remove the lung and the lining and the sac between the heart and the lung and the muscle between the chest and the belly, you have a big hole. So you can see the heart and the aorta there. And that's his lung, including the pleural lining, including the sac around the heart, and including the diaphragm separating the chest and the abdomen. And there's my little hand compared to that big amount of what he had to lose. He also did well, but as you can see, that's a significantly different trauma to his body and what he had to undergo. And he was 47, so he did fine with it. But you can imagine it is better to diagnose early. And that's just a lower cut. So again, no fear, no panic. Arm yourself, establish that game plan, have a roadmap. Patients and people who've been exposed need to ask questions. Seek second opinions from centers of expertise in mesothelioma and asbestos-related diseases. Don't be afraid to speak up. Don't be afraid to question your treatment plan. It's your life in your own hands, and it's important. And any clinician who doesn't receive that well is of concern to me. A clinician should not only be comfortable with that, but should encourage it, because there is no one right plan with this disease, and patients are allowed to advocate for themselves and should. Most importantly, for as long as you feel well, you are well. We will fight with you. So I thank you. This is actually the road well traveled. That was the path around the Charles River, and that was Bill Rogers. He and I ran together in May, and on one of the greatest days of my life. So thank you, and I encourage questions.
Thank you so much, Dr. Wolf. I think what the audience, both here in the room and around the world, have seen is that there are advances being made. It's important that we have people who educate other doctors about history taking, about procedures that are now available, screening tests that we're not utilizing as well as we should. There's hope out there. But again, we'll even be in a better situation if we can stop using this nasty stuff. The question from Dr. Celeste Monfortin to Dr. Moline and Dr. Wolf and others that have spoken this morning is the importance of the medical history and when should that take place. You know, as a physician myself, that is the basis really of all patient interactions, is the medical history. And what we're taught is that 85% of a diagnosis should be based upon getting a history, and the rest of it is working it up. But I'll let my colleagues answer that.
No, I think Dr. Frank is absolutely right. I think it's important for us as patients and as clinicians to let our physicians know of any potential exposures they might have had, even if you have no symptoms, even if it was something many years earlier. But, you know, one patient I think about often is, I've been involved with the World Trade Center medical programs, and there was asbestos there. But this gentleman came because he was concerned about a work-related problem, pulmonary problem. I actually asked him if he'd been at the World Trade Center area because his symptoms were characteristic of World Trade Center-related health problems. And no one had ever asked him that. It turned out he had been clearing out an office for several days right after September 11th. And that was the cause of his breathing trouble. But no one had ever asked him that. So it can extend beyond just where you might have had asbestos exposure. But what we need to do is make sure that people know they might get these exposures. So the press can be very helpful in letting people know when they're reading where there are exposures to various compounds, whatever they might be, so that they say to their doctor at their next well patient visit, you know, I had this exposure, can you put it in my record so that anyone going forward will see that I had this exposure? That's what I recommend to everyone who may have had any type of exposure, whether it was in their youth or whether it was in as a worker. The other thing to do is, if you have your parents still alive, ask them those questions. If there was any home remodeling, if they were diapered with talcum powder or other things before they pass on, so that you have the opportunity, if God forbid, when you are older, and that latency period may be decades, you'll have an answer at least to tell you why you have something.
The question came from Linda Reinstein about the importance of what Dr. Wolf said about empowering patients. what is the importance of empowering patients to ask for holistic care, not just seeing one or another specialist. So, Dr. Wolf.
Thank you for emphasizing that point. I can't emphasize it enough, and we emphasize it in our multidisciplinary tumor boards. And in fact, it's one of the criterion for things like the Commission on Cancer and the NCI to designate a center is that there be multidisciplinary discussion of patients' cases. But they often do come in through one clinician or another, which tends to color what the treatment they would be offered is. And so we have to put that power and that knowledge and that education in the hands of the patients, the caregivers, the public, their primary care doctors, their internists, that it is multidisciplinary. I don't have the right answer by myself at all. That's why I've been so lucky to have such great colleagues and multidisciplinary colleagues. And so I really can't emphasize it enough. If you've only seen one person, you really should see the others, and that treatment plan should be contrived together, because the order of it, we don't know the exact right order. I like to do it one way. My colleagues next door, I always tell patients, if you ask 2 doctors one question, you're going to get 6 answers. And so that's okay, but it is important to have all of those groups together, or inevitably what you're seeing is biased. I always say try to cut it out, and that's what I do. But it's critical, and don't feel embarrassed, don't feel shy. That's the key.
And Dr. Frank, could you mention that anyone seeking centers of excellence and other treatment centers, we have that on the website, we'll make it available.
Yeah, what Linda asked me to repeat is that the ADAO website has centers of excellence, and this points out exactly, 2 quick comments that I want to make, is that there are these centers of excellence for these still unusual and very difficult to treat diseases. A place like Mount Sinai, I go back more than 50 years there, we had 110 specialty clinics. It was a center of excellence for so many different things. But just as patients need to be empowered and educated about their rights and to speak up on their own behalf, this also points out another very serious problem, and that's the lack of proper education of physicians. We still have so many medical schools that have nobody, that Dr. Moline and myself and Steve Markowitz, who spoke, and Brad, who's become one in a sense, trained and experienced in occupational and environmental exposures. It is an area that is woefully undertaught, underappreciated, not just about asbestos, but about almost anything. Years ago, I had a couple of students in a supervised project that they were undertaking to look at 400 medical charts. About 2% had anything resembling a decent exposure history. And, given somewhat of, I won't personalize it that way because I'm not exactly retired yet. But if you take somebody of my age who generally isn't working any longer, what you'll see for occupation is retired. And that is useless.
Stephen, Dr. Markowitz, and Dr. Brad Black have joined on Zoom. I think in closing, if you feel this is the right time, you should ask a parting message as physicians, what patients and family members should do.
I just want to add one thing. It's critical for people to seek out an opinion from a center of excellence. That doesn't mean you have to get, if surgery isn't recommended, the centers of excellence can still guide the local oncologists. And that is one of the key things where you can still get the best care in your communities, but you have to think about making sure that you advocate to look for that best care, but then it can go back, or maybe you have the surgery at the center with Dr. Wolf or with other places around the country, but then the rest of your care, your chemotherapy or anything else, your immunotherapy, whatever else may be able to be done in your community. So that's also something important to think about, but make sure you have the experts weighing in on what is best.
Before we go to Dr. Brad Black and Stephen, I'd like to, as a mesothelioma widow, just have you opine on the fact that there are mental diseases and post-traumatic stress syndrome that we as family members feel in our patients, and I think having our doctors really understand, and if you can cue into that mental health component, it's huge. Suicide is elevated in mesothelioma patients and families, and it's a real problem for mental health. That's my last question. What an excellent panel. Thank you. And Brad and Stephen are back on Zoom.
Yeah. Brad, Stephen, either of you have some additional comments you would like to make and help us close out this, I agree with Linda, excellent session.
So Arthur, in follow-up to what you were talking about, it's just I think that it's just striking to me the lack of understanding of asbestos across the medical community is very poor for many reasons. Probably the biggest is people assume it's something that's gone. They don't have a clue about legacy asbestos and risks. And number two, probably issues related to medical legal drive some physicians away. Overall, it's a lack of discomfort and not knowing is probably the number one reason. And somehow we've failed in education as to how broad this problem is. And until we impact the medical world, we're not going to detect and get the better ways of taking care of people. Obviously, prevention and banning is number one, but in the meantime, we still have legacy, and then we've got a lot of education to do, and somehow we need to figure out how to do that in a way that strikes across the broader medical community. Until we do that, I mean, I don't know how many people we see that go to even pulmonologists. They have no exposure histories at all when they come in with their records. They aren't taking exposure histories that pertain to lung problems. So it's just striking to me that I think disease is being missed frequently throughout the country. So if you don't have better surveillance, you're never going to know, never going to impact the problems that are going to occur from legacy asbestos.
Let me just,
Steve, finish up
yeah.
and
can you hear me okay?
yes, we can. Thanks.
Yeah, so I don't actually have much hope in the medical care system to change with respect to asking patients about their histories, about their exposures. I think we need to get people to advocate for themselves. We need to get people to affirmatively, proactively tell their physicians, their providers, I was exposed, I used talc, I was exposed to asbestos or what have you. And I want that as part of my medical record, and I want screening or whatever is possible to address that, because we've tried for 40 years to educate physicians, and we have made no dent in that. So I really think it's on people themselves to advocate. No surprise in our healthcare system, right? But if you want to take early diagnosis that Dr. Wolf advocates seriously, or the kind of history that Arthur refers to, or Dr. Moline, then I think people are just going to have to put it to their providers and tell them what they were exposed to and what they need, what needs to happen to them, including, by the way, a low-dose CT scan.
Thank you for that, Steve. And I'll just remind this group, I'll let you in on a secret, which is no big secret. The 3 hardest words for a physician: I don't know. Nobody wants to admit that they don't know. And from another infamous phrase, very often they don't know what they don't know. And so they don't act on information that they should be acting upon. So let's bring this to a close. Linda, if you have any announcements to make about timing and how we are to proceed. But I want to thank all of our panelists today, Drs. Wolf, Dr. Moline, Dr. Black, Steve, Laura Baker, all of you for making this such an excellent session in the great tradition of these conferences. Thank you.
And Dr. Frank, thank you for being an excellent moderator. Dr. Oliver, we missed you. And we want you to know when you look at this video that you are loved and missed and so well respected.